Medical Record Pre- and Post-Abstraction, presented by Stefan Villavicencio for the National Birth Defects Prevention Network. Training Overview. This webinar is designed to train program staff who need to collect information from medical records for population-based birth defects surveillance. We will cover fundamental aspects of abstracting information from medical records, approaches to collecting pertinent medical data, quality assessment of abstracted information, and resources to aid with the data collection process. And now let us begin. Introduction to birth defect surveillance. Especially for new staff, these basics can orient abstractors on how to begin. If you are new to abstraction, you will find that the art of abstraction can involve putting all of the pieces of a puzzle together. Case abstraction. What is case abstraction? In the broadest sense, it is the process of recording required information about cases that meet the surveillance case definition per program objective. Program case definition criteria. This is the criteria used by a surveillance program to include birth defects. This definition can be defined at the national level as well as at the program level. Programs may modify their own case definition to be consistent with their own program's needs, objectives, resources, legislative authority, and funding. Changes in the case definition may be driven by changes in funding, as well as by emerging public health issues. The Zika virus threat was an example that led to a re-evaluation of the case definition criteria of microcephaly at both the program and at the national levels. Another recent emerging public health issue was the opioid epidemic and its effect on neonatal abstinence syndrome. Prior to that, there had been a renewed interest in screening for critical congenital heart defects. Keep in mind that emerging public health issues may affect state or federal priorities. Grant priorities can also change the case definition. Also, each program can choose their own method of case identification. As with any surveillance program that would occasionally evaluate their methods for effectiveness, programs could be expected to evaluate and revise their program case definition criteria, as well as their definition of case identification. Hopefully, the program case definition criteria is clear and workable. Program-specific case inclusion/exclusion criteria. Our national case definition criteria, as defined by the NBDPN, are available on the NBDPN website under Birth Defects Surveillance Guidelines, Appendix 3.1, Birth Defects Descriptions. Some examples of categories to include are all structural and chromosomal abnormalities, a subset of NBDPN priority defects, live births only, all pregnancy outcomes, including stillbirths and elective terminations, Only defects confirmed to be present after delivery by exam or by diagnostic testing. All defects, including those suspected but not proven. For example, those noted on prenatal ultrasound but not evaluated after birth. One of the purposes of this webinar is to help new staff understand birth defects. The field of birth defects encompasses a wide variety of health conditions. Because of this and the many state programs involved, it can be challenging to compare birth defect data across the states. By helping staff understand these challenges, we hope to facilitate the accurate comparison of data across states. And now let's discuss case identification methodologies. Case identification methodologies refers to the overall method that a program uses to identify birth defects, potentially meeting the case definition. In other words, it is the ascertainment method that the program uses to conduct birth defects surveillance. There are two types of ascertainment methods: active case ascertainment and passive case ascertainment. Note that programs could use an ascertainment method that combines features of both active and passive ascertainment methods. Passive case identification methodology. Cases of birth defects are reported to the program by the data sources. Examples of data sources include infant or fetal death reports. Another example is hospital discharge index reports that are ICD-10 based. Programs may choose to interact with the data sources to clarify the information reported, since interacting with the data sources could lead to improved reporting. Programs may choose to confirm birth defects with diagnosis verification. In addition, programs may choose to use additional criteria to validate that a diagnosis is real. For example, the number of times a baby appears in different sources with the same codes, or has certain procedure codes, such as surgery. Programs are not required to use diagnosis verification. However, not using diagnosis verification could lead to over or under counting the true number of diagnoses. On the other hand, using diagnosis verification could cost time and could lead to delays in completing cases. Program staff should seek direct access to records from the data source. Programs could use a quality audit that encompasses chart review. Active case identification methodology. Program staff directly access records at the data source or remotely. Prior to the advent of electronic medical records, even before COVID, it was harder for staff to review logs in nurseries or NICUs. Now, reports are received from a variety of departments within a hospital. For example, pathology, labs, and prenatal diagnostic centers. Staff use intensive methods to identify and qualify potential cases of birth defects. Staff review the records of potential cases to determine eligibility based on the program's case definition. Program uses clinical reviewer for complex, random, or specific cases following abstraction. Often, a clinical reviewer will notice something new or unusual about a case. They often recommend that certain cases are good teaching tools for abstractors. They may offer guidance on updating case definition or criteria. Disadvantages of clinical reviewers could be that it's more costly and time-consuming to access sites for reporting and for abstraction. Active case identification terminology. Case finding. It is the process used at each data source to identify cases of birth defects that potentially meet the case definition. This process may include reviewing all records with an ICD-10 CM discharge diagnosis code for a birth defect, reviewing all labor and delivery logs to identify evidence of a potential birth defect. For example, reviewing labor and delivery logs could help find cases where a baby dies there and an ICD code might not be generated. Reviewing the records of all preterm infants or stillbirths to look for a mention of a birth defect. Fetal death certificates might not capture all birth defect diagnoses, which would be picked up in a chart review of these losses. Case culling. Case culling is the process of reviewing the records of potential cases to determine which meet the case definition. For example, when conducting Zika surveillance, case culling would occur when cases were sought where there was less than a 50% chance that we would find cases that are positive for Zika. With case culling, you will always review more cases than you actually abstract. Even if you do not find a case at every review, it is still worth the effort. Now that we've completed case identification, we are ready to discuss data sources. Data sources are locations where programs may identify or obtain information about birth defects potentially meeting the case definition. Such sources include hospitals, such as birth centers, pediatric centers, as well as general and diagnostic indices, genetic clinics, cytogenetic laboratories, prenatal diagnostic centers, vital records, and other state programs, specialty clinics, obstetric and pediatric practice offices, voluntary reports from individual physicians, administrative data set such as Medicaid and hospital discharge data, statewide healthcare administrative databases. The strength of any birth defect program is multiple source ascertainment, as no one source finds everything. Your chances of having complete data is higher when using multiple sources. Review what is known about sources before adding it. For example, getting reports from doctor offices could be time-intensive. Another data source are birth certificates. While they are frequently used by birth defect surveillance programs, they are limited in that they tend to pick up severe diagnoses while missing the more subtle diagnoses, as well as the ones that are diagnosed after the newborn period. New and emerging data sources. HL7 stands for Health Level International 7. This is a set of international standards for transfer of clinical and administrative data between software applications used by various healthcare providers. This data features electronic health records. Data hubs is another type of an emerging data source. A third type of emerging data source is all-payer claims databases. These are claims databases used by insurance and other payers, such as Medicare. Note that not all states use these data sources. So, if you want more information on these data sources, you could ask staff from other birth defects surveillance programs. Now that we have reviewed surveillance terminology and concepts, we are ready to discuss the guidelines for pre-abstraction. Let's begin the second section entitled Pre-abstraction. Data collection facts. Here are some guidelines to consider before arriving to the medical facility. Access to medical record data is important. Surveillance programs, whether using active or passive ascertainment, that review medical records depend on reliable access to medical record data. Understanding information flow is critical. For example, it is important to understand how you get information from Health Information Management, or HIM. It is critical to realize that at some facilities, chart review might not be centralized to HIM. It is also vital to know how hospital IT staff is involved with chart review. Keep in mind, establishing a good working relationship with medical facilities, HIM departments, health, IT, and other critical staff is important to the success of birth defects surveillance programs. Good relationships feature respect. Thus, it is important to respect HIM department rules. HIM Department Facts. Here are more guidelines to consider before your arrival. In particular, these guidelines pertain to the HIM department. Know the HIM business hours and adjust your arrival and departure time accordingly. Submit lists of medical records needed for review in the format that features requester name and organization, and in the time frame required by the HIM department, which could be a 1-week advance notice or a 3-day advance notice. Some hospitals limit abstractor review to legal medical records. As respect was mentioned in the previous slide, respect the time and labor of the HIM department staff responsible for preparing the charts for your review, whether you have reviewed in person or remotely. Avoid canceling scheduled visits to the medical facility. Keep in mind that the medical facility has set aside precious time for you to do your work. To decrease the probability of needing to cancel, try to plan your visits with advance time. If you find yourself in a rare situation in which cancellation is the most practical choice, such as in an unanticipated emergency, always notify the appropriate staff of your cancellation with as much lead time as possible. It is important to maintain hospital relationships when electronic medical record or EMR are accessed, especially when you are accessing records via remote access. Never underestimate the power and benefits of simply saying thank you. Show gratitude for the staff by being cordial, respectful, and appreciative to managers and staff. While these guidelines pertain to the HIM department, consider applying these same guidelines to the other departments you may interact with, such as IT, pathology. Remember, often they are dealing with other challenges as well. If you are dealing with a chain of hospitals, it would be helpful to identify one person who can give you access to charts from any and all hospitals in the same chain. You should also identify individuals from HIM or IT who have previously helped you through access issues, such as obstacles or delays with chart access. Such individuals are likely to be helpful to you in the future. Establishing chart review processes. Identify the individuals who need to be contacted at each facility. Identify the person at the facility who will give you access to the EMR. That contact person should be in the medical records department. Determine the type of EMR access allowed at the facility. Establish the type of EMR access. It could be entire record or restricted access or rolling flat file, printed chart, or a chart burned onto a CD. Make sure that you are able to see the pertinent sections of the chart If this is not the case, then ask for help. Keep in mind, EMR access and processes may vary from hospital to hospital. And be patient. You may need to request information many times. Some facilities scan or use paper records. So be flexible and understanding as the facilities are doing their best to help you. Updating chart review processes. Be aware of changes to HIM management or technology at each facility. Check in with your contact person periodically to determine if HIM management, IT, or medical records have changed. If management has changed, request a meeting to introduce yourself and your program. Keep HIM informed of changes to program staff or methodology. Documentation is important, so check periodically for updates to each hospital's procedures or personnel. It does not help when your contact leaves and the new one doesn't know who you are or what you do. EMR access may change if EMR system changes. Document the end dates for use of the old EMR system. Ask if there are new EMR system training materials available. Establish a point of contact if you have questions or problems accessing or maneuvering through the new systems. Keep in mind, your view in the EMR system may look very different from what they see. Make sure that you are able to see the pertinent sections of the chart. EMR access and processes may vary from hospital to hospital, even if the same EMR system is used. For example, Epic. There are many levels of access to EMRs. Make sure you only access records that you are authorized to access. Fellow abstractors may have identified helpful hints for particular EMRs. Consult them with questions as well. Once an EMR system is active, expect periodic updates as well as periodic changes to login procedures. Requesting medical records. Use the medical record request format and timeframe for submitting chart requests required by the hospital or the program. Before sending the chart request, make sure you have incorporated all protected health information or PHI guidelines utilized by your program. For example, sending chart requests via encrypted email. Record selection criteria may need to be included in medical record requests. Examples include the mother's name and date of birth, the infant's name and date of birth, the medical record number, if known, the abstractor's name, organization, phone number, and confidentiality statement. Some hospitals may require a separate chart request for each chart requested. This may be required because some hospitals scan the chart request into the EMR. Special notes on electronic access. Some hospitals have queues with records loaded for review, and you can only see those specific records. Others provide more open access, which is ideal and often can be advocated for based on the need to access the entire medical record to verify diagnoses. Before heading to the facility, be familiar with your program's data collection tools, program procedures, and program purpose. Check your facility notes to make sure you have the contact person's name and phone number and a copy of the chart request and your passwords to access the EMR. Review the chart request. Are the charts requested all new cases, or are some charts for re-abstracting previously reviewed cases? Make sure you have the tools and resources needed to identify and collect birth defects data. For example, coding manual on birth defects reportable to your program, and resource for looking up definitions, medical procedures, and other information. Remember to take breaks, get up, drink, and eat. Chart review can be emotionally draining. Reading about deaths and defects, and requires good attention to detail. So it is important to refresh yourself. And now let us begin the next section entitled Post-Abstraction. For this section, consider what kind of things you would need to do after you have finished your review. Assessing completeness and accuracy. What should you do to verify if you have all the necessary information? Check for missing data on abstraction forms by reviewing each variable on the abstract. The electronic data system may have built-in range check edits, but these edits only check programmed ranges and cannot tell if the data entered are correct. Sometimes it is easier to see missing or erroneous data when you look at the abstract away from the chart. Ask yourself, based on the history and physical abbreviated H&P, consult assessment and plan, are there expected tests, imaging, or other consults recommended which you have not abstracted? Also, was the infant admitted or transferred to another hospital from which you need to request records? If you are reviewing the record to confirm a case, you might need to update information from the original abstraction. The data you abstract are the foundation of official published results for state programs. So all programs should have ways to capture the most error-free data possible. No one is perfect, of course, so everyone is involved in this effort. Even programs with limited resources can perform some data checks. And now let's discuss basic data field checks for the infant chart. Here are some questions to guide you when you have just finished abstracting some cases and want to check your work. Let's start with the infant record. Is the date of birth or delivery date correct? Do all listed postnatal procedures have a date that is after the date of birth? Is the birth status recorded? Birth status are outcomes such as live birth, stillbirth, or termination. Is the gestational age recorded? Do the defects meet the program's case definition? Is the baby's gender recorded? Does the baby's gender match the karyotype? Is the plurality of the pregnancy, single, twin, or etc., recorded? Do the procedures listed have a date that is reasonable in relationship to the date of birth or delivery date? Keep in mind, abstractors can offer tips to database managers as to what among these quality check questions can be automated as time and resources allow. Things like autofills, automatic calculations of estimated delivery date, abbreviated EDD, when the last maternal period or LMP or ultrasound information is entered and can be time savers. Some systems can be programmed to not allow exit until certain fields are filled in. And now on to basic data field checks for the maternal chart. After completing the checks for the infant record, let's now review our abstraction of maternal information, beginning with these questions. Is the LMP date before the birth date or delivery date? Is the EDD date plausible in relationship to the LMP and the birth date? Is the birth status recorded? Is the gestational age recorded? Are all program-specific prenatal data collected, such as amniocentesis, prenatal ultrasounds, family history, maternal medications, maternal exposures, and maternal illness? Are the number of pregnancies and deliveries correctly recorded, referring to the gravida and the para numbers? Is the plurality of the pregnancy, single, twin, or other, recorded? Do the listed procedures have a date that is reasonable in relationship to the date of birth or the delivery date? For example, are prenatal procedures dated before the date of birth or the date of delivery? Check with your specific program if it has specific requirements about capturing the following information: maternal exposures, maternal illnesses during pregnancy, medications, and other prenatal diagnostic information. Other information to consider include mom's family medical history as found in the mother's record or the genetic consult, and specific prenatal tests such as NIPT and placental pathology reports. Let's discuss checking the validity of the information. Using your program guidelines, does the case meet residency and/or ascertainment area requirements? Check location of the birth address. It may be different from subsequent addresses. When linking with vital records, keep in mind that mothers might move around between conception, the date of birth, and even after the date of birth. Distinguish between the address used during prenatal care and the address used at the time of birth. Confirm with your program on how to establish the ascertainment area. Other important considerations include knowing that military personnel do not have state residency. Check with your program about whether or not to exclude mothers who are not residents of the state. Keep in mind that women occasionally have unexpected deliveries while visiting away from their place of residence. This can also happen to students when living away from home for 9 months out of the year. Be aware that few mothers give up babies for adoption. It may be hard to backtrack an adopted baby by his or her identity, since adoption involves changes in the baby's name, and some post-adoption documentation might not include the biological mother's or father's information. Also consider surrogate births, in which there is a birth mother and an egg donor, where the egg donor is the biological mother and the birth mother is another woman. When adoptions occur, pay special attention to social worker notes. Other adoption documentation could include county court documents, which are often found in the medical record. Note, some state programs have access and linkage to vital statistics. Check with your program to verify this. Final steps. Once cases have been designated as complete, they are ready to include in the data. The next step is submitting these cases for finalization. Cases that are not ready to be submitted are carefully documented. Reasons for cases not being ready include additional information is required or additional review is required. Later, the chart is requested or accessed again. When deciding whether a case is considered complete, it is helpful to use specific criteria to be designated as complete. Some cases might never meet all the criteria for desired information, but can still be counted in surveillance data if they meet specified basic criteria for inclusion. In such instances, these cases can be included as possible or probable. Consider this. Does the case need to be reviewed by the program's clinician or geneticist? Related to this question, how can you be sure that the case is routed to the reviewer and that their comments are received and acted upon? At facilities where EMR is directly accessed, the record will not need to be requested. Some programs may need cases submitted as soon as possible due to the need to interview family for research and or to link the family to services. In such instances, it may be necessary to submit a case for these purposes and then return to the chart for the rest of the information. In such instances, balance between timeliness and completeness. And now let's discuss quality assurance and quality control. Keep in mind that this section is a brief overview of these topics. For more information on the topics of quality assurance and quality control, please refer to the NBDPN website. Quality assurance. Quality assurance, or QA, is a proactive approach to improvement that focuses on prevention. As in many areas of life, prevention is preferred instead of having to identify and repair a problem. Program functions are designed and activities are plan in advance to avoid inaccurate or deficient data. Some examples of program functions include logic edits and date field checks. QA can be implemented in multiple areas of abstraction and surveillance. For example, it can be implemented in case finding, abstraction, medical records review, disease coding, and data entry. QA procedures may include documentation, the use of selective data sources, and the development and maintenance of database infrastructure. QA is cost efficient in the long run. Finding and solving problems can be time-consuming and resource-intensive, and unless a process is fixed, the same problems will continue to recur. Maintaining high-quality data requires continual attention. Quality control, or QC, results provide valuable feedback for the abstraction process. QC is a retrospective and reactive approach. QC procedures may include multi-tiered processes. For example, case finding, re-abstracting, validity audits, timeliness monitoring, and data source evaluations. Re-abstracting QC should include a review of all demographic variables and diagnostic data. QC of the diagnostic data could include a determination if relevant defects have been listed and coded correctly. Data discrepancies are found, resolved, and fixed so that final results are accurate. Use information found during QC analyses to determine if automated checks for some of these issues can be developed. QC identifies gaps in training. For example, if all abstractors fill in a field incorrectly, it is a gap of training and education which can be addressed. Congratulations! You have made it to the last section, which we call resources. In recognition of your accomplishment, which is the completion of this educational webinar, we, the members of NBDPN, provide you with some useful resources that we hope will help you in your future as a medical abstractor of birth defects. If you wish, you can join the NBDPN and participate as a member of the Abstractor Technical Tools Workgroup. For more information, visit the website at nbdpn.org, where you will also find this document created by the NBDPN entitled Guidelines for Conducting Birth Defect Surveillance. What you will not find at nbdpn.org are individual program instructions and procedures. But you should seek those out anyway. Next, here is a list of resources to keep in your abstractor's toolbox. Data collection procedure manuals. Coding manuals such as BPA and ICD-10 CM codes. EMR systems documentation. Hospital systems such as SNOMED nomenclature system. Hospital-specific information, CDC and NBDPN guidelines, medical references, and technical references. For example, standardized medical terminology, or code systems. You can also check with your program for helpful resources for you as an abstractor. Thanks to the present and past members of the NBDPN Abstractor Technical Tools Workgroup who assisted in the creation and development of this webinar. The workgroup is always looking to assist abstractors, and the NBDPN has other committees relevant to birth defect abstraction that provide guidance and support. Good luck in the important work of abstracting information on birth defect cases. Whatever the specific goals of your program, they undoubtedly serve vital public health functions, such as increasing the knowledge base for prevention of birth defects and improving the treatment of children with special healthcare needs.